Welcome back to the Reflection Room. Today we have something new and special. We're going to be interviewing and talking with Dr. Beachkofsky, or Dr. B, and we're going to learn more about mental health for women specifically. She specializes in women's mental health, and she's a board-certified psychiatrist. So we're going to be learning from her today.
Welcome. How are you, Dr. B?
Thank you. I'm doing fabulously. It's a great morning, and I love having these conversations with other mental health professionals. So this is exciting to me. I'm looking forward to this.
Same here. Yeah, we were absolutely excited about today's conversation. And actually, Hannah, I don't think I've shared this with you, but me specifically. So recently I was going through, I don't mind sharing, going through a number of just feeling off, feeling kind of like not myself. And so I actually went to a number of providers and perimenopause actually came up for me. So I am like really looking forward to this. Yeah, I was like shocked. Like, there's no way I'm in that age range. And she's like, you are. So looking forward to this conversation. I thought, I don't know what you guys are thinking, but I'm thinking we can probably even start with that. Maybe if you can provide us just like a foundational definition of what exactly perimenopause is and kind of like the signs to look for. Like for me, I was totally oblivious to what was going on with me personally. So I'm sure there are many other women that might be in this position.
There are so many, and it's not surprising to hear this from you because a similar thing happened to me, and you would think that I would know too, but that's part of why I ended up specializing in women's mental health. So the biggest thing I think to note is that it's a gradual change. So it's something that sort of sneaks up. So there's not something obvious going on. And it can start anywhere in your mid 30s into your mid 40s. So there may be very subtle changes that are happening when you're 37 or 38 that you're not attributing to changes in hormones because it just doesn't seem like it's possible right now. You're still getting your period. Things just seem too normal for that to be the problem. And then suddenly a few years later, you're like, I feel crazy. I'm losing my mind. What happened to me? And that is a little bit easier sometimes for people to catch on to. The other thing is that a lot of times labs aren't helpful. So people will sort of freak out and they're like, oh, I'm 40. I should go get my labs checked and see what they say. And in general, at least from the Menopause Society, that is not a recommendation. We can usually figure things out from talking to people and just kind of explaining what's been going on. We don't necessarily have to draw labs specifically for your hormones to look at that. When we're looking at these changes, though, what's happening is that when you're born, you have your ovaries. Actually, when you're conceived and you have the things that are going to become your ovaries, before you're born, your ovaries are already starting to lose eggs. So that's where we keep our eggs. That's where the most of the estrogen that we have in our bodies comes from. And so as you age, you lose more and more eggs, and those eggs are part of what produces all of the female hormones. So once your ovaries are not doing as much, which tends to happen in mid 30s, they start to kind of do a little bit less than they were doing before because there are less eggs available. Your brain is paying attention. We don't talk often about the ovary brain connection, but that's really where all this stuff is coming from. So your brain gets the signal like, hey, we don't have as much of what we used to have. Like we're low on estrogen. Send us some more stuff. Some of the hormones start ramping up and other ones can't keep up. And so you start to have these things that are happening that just don't look like they used to look. Your cycle typically follows this nice curve path line. That's what it's going to do. It has a nice curve. And then perimenopause hits and it's going like do, 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 do. Yeah, and it's unpredictable. We don't know when it's going to happen for who. We don't know how bad it's going to get. Sometimes if people have really bad like PMS or PMDD or premenstrual exacerbation of some other mood disorder, we find that they might have worse symptoms in perimenopause. And it's not necessarily how high the level gets. A lot of people are like, oh, my level got really high or it got really low. It's not always just the level, it's how quickly it changes. So like you could change very slowly and it could be very high or very low, and it wouldn't feel as bad as when it shoots way up and drops way down. So sort of the intensity of how quickly you have a change can make your symptoms feel worse. So that's another thing to keep in mind. That's another reason why labs just aren't super helpful.
That's a interesting. That's a great question. I'm sure, Hannah, you're probably in the same boat as I am. I'm like, there's so many things I could ask following up from that. I'll just ask a quick one, and then Hannah, you could, follow up. But so interesting because I just completed all of this lab work, believe it or not. So my question then for you, because I'm all about advocacy, like just advocating for our own physical health, mental health when we're working with providers. And so is there anything that a woman should request or ask for if she's being sent to, get all of this lab work done? Is there anything else that we should really be leaning on and depending on? Is it more so just kind of like the client disclosure of just experiences that they're having and just symptoms and just kind of explaining that and trying to like really go into detail to provide as much context to the provider as possible? Or are there other things that we should be looking for?
Sure. So there are things. So one of the first things is there is a screener. I have it on my website. I can share the link with you guys. And if you fill that out, it covers a lot of perimenopause symptoms, and it can help you sort of determine where you're at before you give it to your provider and let them see it and try to figure out what's going on there. And the lab thing that I mentioned, there is a caveat there because it's the hormone labs specifically don't necessarily paint a picture, but we do often want a lot of labs to see if something else is going on. The thyroid, we all know the thyroid is a great masquerader. It like gives all kinds of trouble for mental health because problems with thyroid can cause all kinds of mental health symptoms. So we usually do a thyroid panel. We may look for anemia. Mild anemia can cause worsening in mood. So even if it's like subclinical, it can cause problems. Vitamin D. We will look at other things in labs, especially if the picture doesn't make a lot of sense. But if we can pinpoint it by looking at your age and finding out some information about your cycles, what's going on with your mood, sometimes that's all we need. And it can be tricky. This is not something that I tend to just throw out at people like, oh, you know what? It's probably your hormones. So even coming from your doctor that you might like, it doesn't necessarily sound like something that's warm and fuzzy. So taking a little bit of control to look into what it is, reading about perimenopause. So the last time I checked, I think they're saying there are 34 different symptoms associated with perimenopause. So it's pretty broad. But if you're reading through that and you didn't have these things and now you have these things, I mean, that's a pretty good indicator, yeah, that you've got something else to be looking at. The other thing to be very clear on is this is just like puberty. It's an expected thing. Nobody tells a young girl like, oh, don't worry, you probably won't go through puberty. It'll be fine. Like there's a major problem
You're
if
going
you
through
don't go
it.
through puberty. This is coming. Like if you're going to be 60, you're going to go through this. It may not be as bad as somebody else that you may know, but it's going to happen. No matter what, it's going to happen. So I think it's also really strange that nobody talks about it. Like we don't care anymore. Like once you've had your babies, it's like, oh, that's fine. You can go
Good
out
luck.
there. Who knows? We don't really care. You seem fine. Like go deal with it. So that's the other thing. And it's great right now because it's everywhere. Like I think people are starting to realize like, hey, we didn't get the whole picture and nobody's telling us anything. So we're back in that information stage again. So that's a good thing, I think.
That's a great thing.
Yeah. So I feel like completely in the dark because you're right. Like, we didn't have an education about this. Even in grad school, they were like, yeah, menopause is a thing. But perimenopause, I've never even heard of that until like the past year or two. So, what would you say is the difference between perimenopause and menopause?
Okay. So there's a major difference to me for treating mental health stuff because perimenopause has a lot more, I think, that feels unexplained going on. And women are not necessarily tying it to a hormonal thing. So you feel more irritable, you feel more chaotic, like you're snapping at people, you're not sleeping as well, you wake up in the middle of the night panicking. Sometimes you might even be having night sweats, like vasomotor symptoms. And you're not even really realizing it because they're not that bad, but something's waking you up, something's making you feel off, and that can feel really concerning. And nobody's really thinking like, oh, this is because it's menopause coming. Like that's just not how our brains have been raised to think. I don't think most people think that right away. Menopause, I think for people feels more obvious in some ways because we're seeing the end of a cycle. So we don't diagnose menopause. It's one day, and it's the day that's like after you haven't had a period for a year, then we can say you're in menopause now. And then everything after that is postmenopause. So it's kind of, the verbiage is a little bit weird, but some things in menopause can be worse. Like people can have pretty bad night sweats or hot flashes. But a lot of the symptoms that feel so crazy during perimenopause have smoothed out some, because by the nature of being in menopause, you're not getting these crazy ups and downs with the hormones anymore. They're more level and they're also more low. So they're down here, but they're not changing a lot. And it's that change that we know creates a lot of chaos for people.
Hmm. Yeah, that's really helpful. And you're right. You're right, Hannah. I don't think I mean, you hear about menopause, which I love the how you said it's such a great area there with like perimenopause, menopause, and then postmenopause, Dr. B. But you're right. There's not a lot of information on perimenopause, and as you were talking just now, I was thinking about how important. That's why these kinds of conversations are so important to have, and even what the information and resources you provide, Dr. B, on your website that I was kind of scrolling through and saying, I think about what mental health looked like for us as women originally back in the day, and I think of the term hysteria, and I feel like from the very onset as women, we've been provided like, I mean, to put it nicely, the short end of the stick, but really it's like misinformation, being misguided, misunderstood, being labeled for things that are just not accurate. And I think some of that stuff still happens today where we might not necessarily use the word hysteria, but it's like, oh, she's just PMSing or just so moody or what's going on with you today or here she goes, or I don't know what side of you I'm going to get today. I think there's still a limited understanding of what we as women go through naturally and I guess hormonally, right? A lot of it's caused by hormones. So I know sometimes we have men even that like listen to our podcast, and we might even have those that are in their 20s that are listening to it, and they might say like, I don't really know what this has to do with me, but I think it has a lot to do with them. I think we all have women in our lives. If it's not us, we have women in our lives that are going through what exactly we're talking about today. So can you talk a little bit about the stigma or just ways to kind of destigmatize this if we are women, who we might find ourselves in the perimenopause stage, but then also trying to understand our loved ones too, and like the right language to use to make sure that women are feeling heard and understood and not, kind of pushed aside and overlooked. So any thoughts come to mind about all?
Sure. So the first thing I'll touch on is how to talk to somebody else who might be having some hormone problems. And that's because I recently talked to a couple of psychologist friends who I was like, I don't know. One of my male patients was like, I think my wife is in perimenopause and I don't know how to tell her because she's just going to be mad at me no matter what. But after talking to these smart women, they were like, just use a lot of I statements. So I have noticed these things. I have seen on social media that there's a lot of information out there about this thing, perimenopause, or whatever feels like the right language to use. But yeah, using the I statements about like, I just want you to feel better. And it sounds like there are things out there that you could try that might be able to help. I think coming from a helping place, caring, like just making observations without judgment, hopefully. That's a nice way to bring that up to somebody else. But I think people in general, we do like to find differences, right? Like as a culture, like we just like to find differences. Like you're different from me, and these are the ways that you're different from me. And women try so hard sometimes, especially like in the workplace and with their friends of different ages and trying to get along with other people. They don't want to identify changes in hormones as another thing because it's been the butt of jokes for so long. And before that, just terrible, terrible treatment. Like it doesn't have a good history, as is often the case with people in medicine. So it's not a great history and it's not a great look. So even though hormone therapy used to be really common 20, 30 years ago, this was not a taboo subject and people were being treated for it. We didn't do it quite as well. Sometimes people were at more risk than they should have been medically with the treatment. but it was an accepted thing. It was just something that lots of people did. And now women are being shamed in a lot of ways. Like, oh, you can't identify this thing. Like, you have to be tough and strong and don't bring that to work. And now we're not talking about it. And now there's a whole bunch of us out there that are like, what the heck is going on? So I think being thoughtful about that this is a body thing. This is a body brain thing. This is physiologic. This is not you want a day off from work because you don't feel like going in. It really has a big impact on the workforce because there are so many women in the workforce, and there are plenty of women that are at the tops of their careers in their days, which is when they're going to experience the most significant symptoms. So it's important to recognize that this is medical. I also think that's funny when I have people fill out their intake paperwork. I always like to make note of the people that include depression and anxiety in the mental health history and also in their medical history, because almost nobody does it. But it's part of your medical history too, because your brain is the thing that's doing all the stuff, and that's an organ. So it's doing a lot of the havoc that you're dealing with. But it is a tough subject. There are going to be people that don't understand and don't want to hear it, and that's okay. You're not there to tell everybody about all the things. But if you have women in your life who might be going through this and it's not you, you should probably share some information if you have some. And if you are going through it, you should share it with everyone that you can to help explain what's going on. Even if you don't go through any kind of treatment, like I'm not out there telling everybody to go on hormones or anything like that. This is a natural transition. This is going to happen. We have things that might ease it as you move through the transition, but it's going to happen no matter what. So letting other people know that this is what's going on with me. I don't mean to snap, but sometimes that happens because of what's going on with my hormones and I can't really control it.
And Hannah, you might have a follow-up question, but I just want to share quickly. I love how, believe it or not, this husband came to you and said, I think my wife might be going through this. Whether or not that was the case, I don't know. But just the fact that he was aware and wanting to learn and soak up knowledge and information, and then also how to appropriately approach his wife about this topic that, I can be sensitive for someone personally, but even like we just said, the way that it's presented oftentimes, in our larger society is just inaccurate. So it could just be difficult to talk about. And you're right about like women in the workplace. There are a lot of women are, like really beginning to, I think everyone in general begin to kind of like find their space in their 40s and 50s in the workplace and kind of settle in their positions and stuff. And so you have a lot of women that are in these higher positions that are, trying to deal with the normal stressors of the workplace, but then also are dealing with something like this so privately and personally, and may not feel necessarily comfortable to share that. I mean, I know some women personally that have struggled to share with their employers that they're pregnant, let alone something like this, right? Because it may not necessarily be received well. And so that's why I think these conversations can be helpful. So we're aware that there are so many other factors that might be contributing to situations that we encounter with women that just might show up one day and just seem a little bit not like themselves, and just really trying to come from a place of understanding, I think is key.
Yeah.
Exactly. Yeah, for sure.
Yeah. And I did have a question about something you said earlier. You were talking about like from a provider standpoint, not wanting to just be like, oh, it's your hormones, or kind of like, I can see how that would feel like a dismissal to some people, like if they weren't prepared for that answer and they come in with like a serious concern or worry, and then their provider says, oh, it's probably your hormones. I can see how that can be very frustrating. So how do you handle that? And I'm thinking of it in our setting as well with clients, because I have some that have come to me with, now I'm in perimenopause and this is how do we deal with this? But if I were to be thinking, what if this could be hormonal, approaching that with them without being dismissive, how would you approach that?
So with that, so from where I come from, none of it is dismissive, but I think that comes because I have people, right? In mental health, people come sometimes with concerns that they have already been dismissed plenty of times, like, oh, your anxiety, like whatever, that's no big deal. So I'm already a little bit more sensitive to that. I would like to say that medicine is maybe catching up now. I'm hearing about some programs that are teaching in medical school something about perimenopause and menopause, but I went through my entire medical school and all 4 years of residency, and nobody said perimenopause ever. And we didn't focus on menopause even at all. And there are some significant changes that we need to address with people from a mental health standpoint, because it's a shift in your personality and who you identify as. And we treat that like it's nothing. We don't like, oh yeah, whatever. Like that's fine. We'll work through it in therapy. It is again coming back to the body. You can blame your body and your brain for all the things. It doesn't mean you don't still have to take responsibility for what's going on, but it can feel so much better to know that there's a thing that you can blame for how you're feeling or how you're doing or what's to come. Like it can feel nice to have a target. And then you can just kind of come to terms with how you're going to work through that. And I think it makes it a little bit easier, because this is something that everybody is going to go through if they were born with ovaries. Like it's going to happen. So I think normalizing that for people and explaining the physiology behind it and say, like, this is what's happening. Now, about 10 to 15% of women don't really have problems. Like they don't really have any complaints. They don't really notice that anything is going on. I love those women. You are
Yes.
fabulous.
That
Yay
sounds
for
great.
you. Please don't brag to all of your friends who are suffering, but you can tell your kids, because that's also important. Like let them know a lot of it is genetic, so that's helpful. And that's another thing too that can help sort of bridge some of the gaps, is talking to family. So if somebody does have family members available to talk to, aunts, parents, like, Mom, when did you go through menopause? Sometimes people will know, and sometimes people don't want to talk about it. But that can be really helpful because there is a genetic component to all of this. Generally, if your mom went through menopause later, like after 51, you are likely to go through menopause later. Same thing if you go through it earlier. So that's the kind of thing that information is helpful. Did you have a lot of hot flashes when you went through menopause, or was it not so bad? Like these kinds of things can be helpful, and it opens that conversation. If you have siblings, if there are cousins, you know what I mean? That it can kind of open up the conversation to be like, that happened. We should share that with the other women in our family as a heads up that this is happening. So when I talk to people, I try to just make it like, let's just talk about this. Let's make it available for other people. If you have friends, like talk about this. Let them know what you're finding out and what's happening to you. Maybe they will be that lucky 10 to 12%. Maybe they won't. But getting some information is going to be really helpful for trying to navigate when things feel chaotic, but there's a reason why.
Yeah. Oh, I love that.
Yeah, that's very helpful. And I think that when you mentioned just having like a label or just a term that can help you understand what you're going through, and I think that's helpful not just with this, obviously, but as providers, I think we can understand that there are clients that come to our offices or spaces and they want to know these are my symptoms. Like, what exactly is
What is it?
happening? Like, what disorder do I have? Like,
Yeah.
what syndrome, and sometimes, we gauge whether or not it's helpful to really kind of go into detail. Sometimes so we naturally are looking for crutches to kind of hold on to as human beings. But for those people that truly want to know, a lot of times they have just been going through life struggling, or maybe there was a season that they have just really been struggling and not gotten any answers. Sometimes they've gone from provider to provider, and then finally they're like, wait, I think this is there's an emotional like component to this. And so, and then having a label or clinical terms that they could use to then say like, oh, okay, so I'm not, it's not just me, but this exists and this is what's happening. And now that I have a better understanding of it, I can research it, I can work with the right providers, and then arrive at some kind of solution or treatment. So that was great. That was great feedback, Dr. B.
That's really helpful. People knowing that it's a real thing, that there are resources that they can look at, and that they're not alone in this. Medical, as you mentioned, the medical system, it can be very, very divided as far as you see this person for this problem and this person for this problem. And so you might see 5 different people because you're having problems with your skin and your hair and having problems with your brain, like all these things. And you're going to see all these people, and it's not being looked at as a whole to say like, oh, wait, you're having all these symptoms and they're all on this list for this one thing that goes on for everybody, all people that had ovaries. So I think that can be really helpful for people. I really do. Just calling it out, saying what it is, and trying to open the conversation.
Yeah, that's great. I really think we can do a better job at like coordinating care for sure. I think that's a huge need in just our like medical or clinical field, I would say, is just being able to kind of coordinate care. And for those of us that know it's okay to, bring your lab work or bring your doctor's notes and take it to another provider and say, this is what, this provider has said. What are your thoughts? Like, not everyone knows they can do that or they feel comfortable doing that, or maybe they might feel like I don't want to disrespect and tell them like, I've seen these people, this is what they've said. But no, we encourage that. We definitely do, and we do our best we can too at our practice. If there's a psychiatrist or if there's a medical provider that wants to chat and we have that release of information, we do the best we can, because that's the way we're going to provide our clients with the best care possible. So yeah, I think that was really great. Hannah, I don't know if you're thinking this, but one of the things that we do, Dr. B, in our channel, The Reflection Room, is that we are always looking to see if we can debunk myths that are out there. I don't know if you feel this way, but I do. And Hannah and I, we've talked about this and we talked about it on other episodes. But sometimes I'm scrolling on social media or I'm just looking or even watching a show and I'm just like, oh, that was not accurate. That was such a skewed perspective of things. And so I just want to hop on and just like type away on social media and say like, this is the truth or this is how it really is. There's just so much information out there and everybody has the ability to just put their opinions and perspectives out there. It's all at the tips of their fingers. So are there any myths that you would like to debunk that's related to this area of specialty for you?
For sure. So let's see. Myths. So one of my favorites, I'm just going to come at one of the things that I hear is that because of the gift of modern medicine, women are finally living past the health of their ovaries to go on and have this menopause that never should have happened, which is completely untrue. Like, we have plenty of records from hundreds of thousands of years ago that there were lots of women that lived into old age, what we consider right now not to 40. They lived into their 60s and 70s. We have bone data. We can carbon date it and see how old these people were, and they were fine. And they went through menopause too. It is not because like modern medicine is keeping people alive and now we have this menopause thing to deal with. That drives me nuts. There are a couple of other animals. My favorite one is the killer whale. So orcas. Orcas are another species that the matriarchs live well beyond their reproductive years, and they have really good stuff that they do for the pod. It's really important and helpful. The whales wouldn't survive very well without those non-reproductive matriarchs around to like teach things and keep everybody safe and get food. So that's one that drives me nuts, because it's like, oh, should we thank all of the men in modern medicine and be like, oh, thank you for letting us live long enough that now we can struggle in menopause? It's just totally silly. One of the other ones would be the only treatment is hormones. There are lots of treatments for things that are not hormonally based. Many of them are mental health medications, but they're not all. There are lots of things we can do for hot flashes or for losing bone density. Like, there's a lot of treatments for things. And so that's another piece, just because, and especially for women that are concerned because they've had breast cancer or some other reproductive cancer that they can't even choose hormones as an option. There are always some options that we can try to help ease some of the symptoms that they're going through. Oh, the other thing is that it is hormones. Like, people always are like, it's just perimenopause. It's just menopause. That's all it is. This one is very tricky because hormones are not magic. Obviously, we've had hormones in our bodies all along, and have we been magical? I mean, we can make babies sometimes, but like it's not really magic. Hormones aren't always a gift. And just because you go on hormones doesn't mean it's going to solve all your problems. Some of this is aging. Some of the weight gain is age related and not hormone related. changes in hair and skin. A lot of these things are not simply hormonal issues. So just because you're like, oh, I feel this way or I'm getting older, it must be I need my hormones. And some of that myth does come from the older hormone treatments. In the 60s and 70s, there was a big push like feminine forever. Like you can be a fabulous, gorgeous woman for your man at home if only you take these hormones. And like there was a lot of, I mean, who doesn't want that, right? Like, okay, that sounds great. But yeah, so it's also not always the answer. So even though you can look at that list and be like, oh yeah, I have a lot of those things, there are multifactorial reasons why you may experience something. That's a less fun myth because I want to tell everybody like, we can fix this, but sometimes we can't fix it like exactly the way you want it fixed.
Yeah, that was helpful. Don't you love reading older articles or clinical
Commercial.
books? Yeah, or commercial. Yeah, and you're just like, oh gosh, I'm so right. So I can only imagine 30, 40, 100 years from now what they might look at, what we're practicing.
That we're doing this.
Yeah, but that was really helpful actually. So yeah, thank you for sharing that.
Sure.
This has been it's been such a great time just like chatting and talking about this when Hannah shared with me that we had the opportunity to chat with you. I said, oh, absolutely, especially about topics like this that don't get a lot of attention or time, and not intentionally. I think sometimes people don't even know what needs to be talked about in order to even talk about it. So this was extremely helpful. Is there anything else you can think of, Dr. B, that you think would be helpful for our viewers and listeners to know when it comes to this?
I think probably one of the best things, if you are seeing a mental health provider and you have concerns for this, go ahead, of course, and do your own research, but talk to your mental health person about this as well. And there's a very specific reason why. If you go to your gynecologist with this long list of stuff, you will not be happy. It will not get addressed. They do not have time set aside in their schedule for your 15-minute checkup that they're going to talk to you about the whole course of what's going on with your hormones for the next 15 years. It's just not built into the way that they function. But in mental health, we're very gifted with time. That is part of what we do. And so even if your mental health provider might not be somebody who really knows a whole lot about this, it's still great to have that other person that you can have this conversation with, kind of work through things, and then maybe even they can help you hone in on some of your most important questions. And then you can call your clinic and say, I have a specific question I want to talk to my gynecologist about. Can you put that in the appointment so that she knows that's what we're going to discuss? Because they're not going to be prepared. So if you have your specialist that you like to see, that you want to continue to see, or your primary care doctor, this is another person, they're just not designed to like answer all of your questions about something. So if you can work with your mental health person to sort of hone in on what's the most important question you could get answered in 15 minutes, that might be really, really helpful, because there's so many people that aren't trained in it. You're not going to very easily find somebody necessarily who can just help you with all the things and has all the time to even address all of your things. So I think by taking advantage of the time you have with your mental health person and just saying like, hey, we're doing all this work and I feel like I'm not getting as far as I could. Like, I wonder if like maybe hormones are playing a part. This is what I found. Can we talk about this some more? Can you help me figure out how I can talk to my doctor about this?
Yeah, I love that because we're trained to be able to identify like if something could be physical. Like we don't want, like, for example, if someone comes in with chest pain, well, yeah, it could be anxiety, but what if it isn't?
It's not.
Yeah, so it's good to know like we can have those conversations too and be able to say like, okay, you should see a doctor and we can map out what you need to say exactly to get this taken care of.
Yeah. I think that can be really, really helpful. And this isn't, some women get caught up like, oh, well, this will pass and it'll be fine. And that may be true, but there are some medical implications of going without hormones for a long period of time. So if you are on the earlier spectrum of things, it is also another important thing to talk to a medical provider about, because if you're going without estrogen, say 10 years longer than somebody else, some of the implications of that are osteoporosis. You're more likely to lose bone density and be at risk of fractures, which puts you at risk of death. Like as you get
Yeah.
older, a fracture could be the beginning of the end. Or things like cardiovascular disease, that increases. Once women are no longer having that hormonal impact from their ovaries, we see a rise in cardiovascular disease. So we do think that there are some links between hormones, because their estrogen receptors are everywhere in your body. But just recognize that, again, it is a medical situation. This is physiologic, and there are things we can try to do about it. But it's also not just benign. It's not just a nothing thing. You should look into it and see what is the recommendation for you.
Yeah, that's great. I go back to that advocacy word. I think it's so important for women specifically who might have just heard you see that, Dr. B. It's like they recognize, okay, wait, I can do something about this, or there are people out there that specialize in this area, or maybe it is something that yes, it's physiological, and yes, it's medical, and it's a biological component to part of life, but there are things I can do that could help either help me kind of go through the process or ease some of that.
Yeah.
Maybe there are natural remedies that we could also kind of look into. So that was really great to hear. I feel like we can go on, and I know I have so many questions, so we might have to do a part two. But if any of our listeners or viewers are interested in learning a little bit more about this topic, where can they find you, Dr. B?
So you can find me through my website, which is jessicabeachkofsky.com. And I put up a whole bunch of stuff on there. I have a bunch of resources that are not mine. I have a blog where I write stuff. I have a YouTube channel that is geared more towards therapists, but is also appropriate for people who are curious about stuff. And I've been adding more perimenopause and menopause stuff on there because it's a topic that I get asked about. So that's Brain Bites with Dr. B. And then I'm also on LinkedIn.
Oh, well, this was so helpful. I really appreciate your time. Thank you so much for taking the time to meet with us. It's been
Excellent.
really great. Yeah, thank you. Well, thank you guys for watching, and thank you for listening. And hopefully we will see you guys next time. And until then, keep reflecting.